Welcome to Powerhouse MD. Today, we're going to be going over aortic stenosis. We're going to start with a case presentation. So after collapsing at a street fair, a 62-year-old man is brought into the ER by ambulance. The patient arrives at the hospital at ANO ×3 and can answer questions. The patient states he has a past medical history of type 2 diabetes, hypertension, and hyperlipidemia. The patient states he has smoked half packs per day for the last 30 years and has enjoyed 1 to 2 beers a night for the past 5 years. The patient also states that this happened 6 months ago, but the ER cleared him. He has also experienced some weakness and dizziness when walking for an extended period of time, has recently developed chest pains that happen during exercise and while sitting, and has had shortness of breath inconsistently. On physical exam, the patient appears to be in no distress. Heart rate is 86, blood pressure is 172/94, and respiration rate is 16, and temperature is 98.6. Upon auscultation, a clear crescendo-decrescendo is heard at the right sternal border at the second intercostal space. Physician orders an EKG which depicts a left axis deviation in atrial fibrillation. What would the physician's diagnosis be? So here we have, through the crescendo-decrescendo, is what looks to be aortic stenosis. So a couple things on aortic stenosis. The aortic valve is situated between the left aortic ventricle and the aorta. It is made up of 3 leaflets and called a similar valve because it has crescent moon shape. It occurs when the leaflet becomes too stiff and unable to open fully, and this leads to a layering of the left ventricular outflow tract, which means the heart has to pump harder. So a couple things from this vignette that we're going to pull out. The man is 62 years old. He has type 2 diabetes, hypertension, hyperlipidemia, has smoked. This happened 6 months ago, the syncope episode. He has some weakness and dizziness when walking, so on exertion. He also has chest pains that are during exercise and while no exercise, as well as shortness of breath that occurs on and off. His blood pressure is hypertensive at 172/94. And of course, like I mentioned earlier, the crescendo-decrescendo murmur, right sternal border, second intercostal space. There's also left axis deviation and atrial fibrillation. We'll get into left axis deviation shortly, as well as atrial fibrillation. Aortic stenosis patients are asymptomatic for years, with the first indication being crescendo-decrescendo systolic ejection murmur. The 3 cardinal signs of aortic stenosis is syncope, angina, and dyspnea. Please know it as SAD for the acronym. Other symptoms include weakness, dizziness upon exertion, and palpitations. It is crucial to diagnose early through the murmur. Severe aortic stenosis can lead to atrial fibrillations, larger and more lateral point of maximal impulse, crackles heard on lung exam due to pulmonary edema, jugular vein distension, and peripheral edema. When syncope develops, this is due to decreased blood flow, and typically there's 3 years survival following these symptoms. When angina develops, decreased blood flow through the coronary arteries, which branch off the aorta immediately, and typically there's a 5-year survival following these symptoms. When dyspnea develops, this is due to the increased pressure load on the left ventricle, eventually causing hypertrophy and causes muscles to weaken, leading to the backup of fluid in the lungs. Typically, there's a 2-year survival following these symptoms. Patients with aortic stenosis also have an increased risk in developing strokes due to thrombi leaving the left atrium. Another important thing to know is super high yield is pulsus parvus et tardus. This is one of the symptoms that can happen with aortic stenosis, especially in severe aortic stenosis. Basically, this is weak pulses with delayed peak. Some risk factors include old age, which affects 5% of this population, male sex, smoking, hypertension, high levels of LDL, and diabetes mellitus. Age-related calcification is due to wear and tear that occurs throughout the years. You can also see this in younger patients that have congenital bicuspid valve, which affects 1 to 2% of the population. The 2 leaflets cannot withstand the normal wear and tear and can calcify more easily. Individuals with congenital bicuspid valves usually develop aortic stenosis in their early 40s to 50s compared to 60s, 70s with your basic age-related one. It can be associated with aortic root dilation or aortic aneurysm as well. Williams syndrome, which will be covered in a different video, is a rare genetic disorder characterized by mild to moderate learning difficulties or cognitive development. You also have rheumatic heart disease, which is an autoimmune disease caused by rheumatic fever that develops from a Streptococcus pyogenes infection. If left untreated, the body creates antibodies to the M surface protein on the bacteria that mimics a protein present on the lining of the heart. The immune system attacks the lining of the heart, specifically the valves, which leads to inflammation and scarring of the heart valves. Eventually, this will lead to calcification. Streptococcus pyogenes will be covered in another video. Lastly, you have angiodysplasia and macroangiopathic hemolytic anemia. This hemolytic anemia is caused secondary to mechanical destruction of the red blood cells as they pass through the narrowed valves. Here we have some histology for it. As you can see here on these lines right here, you have the beginning of the calcification of the aortic valve. Pathology is huge on the step, so I put in a couple pathology slides to highlight aortic stenosis. In this histology image, you can also see the calcification present right around here, circled in red. Here you see better depiction on the grade. You have grade 1 with just basic calcification. You get a little thicker calcification in grade 2, and you can see like what looks like but isn't plaques, but more calcification on the valve. You can see it also in the alizarin red stain. The calcification is the density now of the valve, which is causing it to become heavy, stiffer, unable to open, and you can see it completely eroding the valve in this last grade. Again, please make note of all pathological images. There are histological images as well as pathological images coming up, as they're imperative to know for your step exam. Now we're moving on to the pathological slides of aortic stenosis. Aortic stenosis is caused by dystrophic calcification, which has calcium deposits in the abnormal and diseased tissue. You can kind of see the calcium deposits here as it is the thickening. This does not present with increased calcium levels, serum calcium levels, and is usually localized. This is compared to other sorts of calcification that you will learn in future videos. Acceleration of calcification can be caused by hemodialysis, osteoporosis, Paget's disease, and vitamin D receptor polymorphism. So this can lead to quicker development of aortic stenosis. So you'd see it generally in younger patients, probably in their 50s, if they do go through hemodialysis or they have extensive osteoporosis. So you can see in the image I just circled, the calcification, you can kind of see the deposits on those valves. You can see the narrow opening. And then on the right, you see a narrow opening, not as narrow, but you can more easily see the images, the thickening of the valves. You can see this cross. If I were to make a cross section of it, you'd see it is much thicker than what the typical valve should be compared to this side. The valves are not as thick as this. Now we're moving on to the physiological aspects. Right here, you can see that between S1 and S2, the sound is where you would hear the systolic crescendo decrescendo murmur, usually at the heart base, at the right sternal border of the second intercostal space. This is also, again, this is your systolic period. This is when the blood is going through the valves. The murmur is due to turbulent blood flow through the stenotic valve. A later peaking murmur, however, indicates severe stenosis due to the valve being stiffer and taking longer to open. This murmur also radiates towards the carotid. A soft S2 is heard with or without an ejection click. So ejection click can sometimes be in the vignette that will point you towards aortic stenosis, but it doesn't always have to be in the vignette. As you can see in this Wigger's diagram on the left, there is a drastic increase in left ventricular pressure, especially compared to the aortic pressure. This pressure is what leads to decreased ventricular compliance and left ventricular hypertrophy. This left ventricular hypertrophy is what leads to a left axis deviation on your EKG. So please do remember, even for any other type of disorders, if it says left axis deviation, more times than not, it's going to be left ventricular hypertrophy, and sometimes can be displayed with a left bundle branch block. So please keep that connection in mind. On the right, you do have the left ventricular pressure volume loop. There is minimal no change in the end diastolic volume as you see here, but there is an increase in the end systolic volume. This means that the stroke volume decreases, which correlates with a decrease in pulse pressure. Remember, they have a direct relationship, pulse pressure and stroke volume. This can also be seen in that both the systolic and diastolic pressures increase in aortic stenosis, especially with this increase in afterload that you see here. Another important thing to note is that heart sounds. So when you have aortic stenosis, you will also have paradoxal splitting of the S2. As you can see, S1 is standard. The pulmonary valve and the aortic valve are in sync mostly together, so you only hear one heart sound. However, in expiration, there is delay in the aortic valve due to the stenosis. So there is pulmonary valve closes first before aortic valve. However, in the normal heart, it is usually the aortic valve that closes first. So this reversed orientation is what's led it to be called paradoxal splitting. Some bedside maneuvers, also important to note with aortic stenosis. Standing in Valsalva decreases preload and decreases the left ventricular volume, which leads to a decrease in blood flow. which is why you have a decrease in murmur. Hand grip greatly increases afterload and increases the reverse flow across the aortic valve, increasing left ventricular volume. However, there is a decrease in the transaortic valve pressure gradient, so this aortic stenosis still decreases with this. Inspiration increases venous return to the right heart and decreases venous return to the left heart, which is again why you have a decrease in murmur. Passive lag, however, and squatting both lead to an increase in preload, which leads to an increase in left ventricular volume, increasing the flow through the stenotic valve, which is why you have an increase in murmur. These will come up not only in your practice questions, but on the steps. So please know your bedside maneuvers. In each video covering the cardiac murmurs, I will be addressing the bedside maneuvers for that. Diagnosis. So you have the cardiac ultrasound. Shows thickening and calcification of the aortic valve along with any malformations that may be present on the valve. You have the Doppler echocardiography, which determines the amount of flow through the aortic valve and the pressure gradient between the left ventricle and the aorta. This is important in determining the type of treatment for aortic stenosis. Lastly, you have the left and right heart catheterization. This is the gold standard if Doppler is indeterminate. This determines the pressure difference on either side of the aortic valve, revealing any restrictions. Lastly, we'll be covering treatments. The only definitive treatment in aortic stenosis is aortic valve replacement. There is no conventional treatment, but there is medications given to control blood pressure. Severe aortic stenosis is preload dependent because it needs enough of the blood and pressure to push blood through the narrowed valves. Anything that drops the preload by dilating veins can be potentially dangerous for patients with severe aortic stenosis. Therefore, you should not prescribe anything that decreases preload, such as nitroglycerin or any other venodilators. You do not prescribe it without listening for a murmur first. That is the most important thing, because a lot of times aortic stenosis, as I mentioned, is asymptomatic. The murmur is what's going to tell you firsthand if you have aortic stenosis before you get to your symptoms. So you need to listen to the murmurs before you give any sort of venodilators if you're working in the ER. Like with most conditions, though, lifestyle changes can be beneficial in managing the symptoms. So this is all I have for you today. Hopefully you learned something. Hopefully you took something away. Please look forward to more videos in the future. And right now it's a small amount of you watching. You have a way to contact me. Let me know if there's anything you'd like to change, or let me know of any topic you would like to have covered. Thank you and have a great day.